Hello everyone, this is Shadi Reyes and this is SIF 2022. With me is Dr. Carlos Sanchez. He's Director of Structural Heart at Ohio Health in Riverside. So Carlos, always a pleasure to see you. I know you do a lot of traveling, proctoring, and you are a heavy structural interventionist. We spoke a little bit offline about the role of ICE for structural heart, especially Watchman. It's becoming it's coming new technology, completely putting away the TEE. Tell us about your experience and where do you see this going?
So, Shadi, first of all, thank you for having me here. It's a pleasure and great to see you again. This is a very hot topic nowadays because a lot of the EP and interventional community are trying to find ways to minimize the approach to treat patients for left atrial appendage occlusion. And one way of doing it is with intracardiac echocardiography. You know, we started with 2D ICE, now we're moving to 3D ICE. Some companies call it 4D ICE. But this is a very good way where you can do the procedure under conscious sedation, no general anesthesia obviously, and no TEE. Allows you to recover the patient faster throughput also in patient care, and also allows you to do same-day discharge.
That's great. And just for the audience, what is the difference between 3D and 4D?
So it's more a branding name. There are three major companies right now with 3D ICE. That is Philips, Siemens, and Biosense Webster. Mm-hmm. And Siemens has the Acuna Volume ICE. They brand it as 4D ICE. And 4D ICE is nothing else but a live 3D picture. And that's how they call it 4D ICE. Okay. Whether you agree or not. Philips call it 3D ICE, but it's exactly the same.
Yeah. So now, what is the learning curve for operator to move from TEE to completely ICE? Because you as interventionists, you are maneuvering the ICE, right?
Correct.
You are seeing what you are going and this is what you're guiding.
Correct. So there is a learning curve to do ICE. I would recommend that the operators first feel very comfortable doing LAA closure with whatever device they choose with TEE and general anesthesia, just like the IFU. Once you feel very comfortable, you can start moving on and, you know, call it 10, 20 cases. Everyone's different, but once you feel very comfortable with TEE guided LAA closure, then you can start moving to ICE. I think there is a learning curve, especially if you try to image the left atrial appendage from the left atrium.
Right. You are a national proctor. Do you think this thing should be proctored as well, the ICE learning for Watchman?
No doubt. I think especially if you don't have any experience with intracardiac echocardiography, and you're going to start a program with ICE, you should be proctor, not just to understand that technology, but also from a safety perspective and make sure you're following the appropriate protocol for the procedure.
Absolutely. So now we don't do TEE. So how you are sizing pre-procedure? Are you depending on CT scans or you still do TEE pre?
Yeah, that's a great question. We do every single ICE left atrial appendage closure. We do a CT angiography. And the CT angiography help us for two major things. One, sizing of the device, but also help us assess any left atrial appendage thrombus prior to the procedure. And there is a specific protocol, a delayed image acquisition that you have to do it. It's not just like a TAVR CT, so there is a protocol to make sure that the left atrial appendages are pacified by IV dye, and that you don't have false positive results for thrombus.
Yeah. So now your practice shifting completely to CTA before the Watchman?
Exactly right. Wow. And interestingly, we're doing also post-Watchman or Amulet also. CT
for positioning and so.
Yeah, so or 45 days follow-up or the follow-up necessary to take the patient off anticoagulation specifically for the Watchman device.
Interesting. I was about this. My next question: what's your protocol for antiplatelet or anticoagulation post-implantation?
For Watchman Flex, we follow the same protocol as IFU. So we try to put the patients on anticoagulation 3 weeks before, at least 3 weeks before the procedure, and then we put them back for 45 days. We then transition to DAPT, aspirin and Plavix, if they don't have any bleeding issues by then, and then finally aspirin. For Amulet device, the IFU is a little different. You can go straight to aspirin and Plavix. And I know Boston is working on trying to get the eliminate the anticoagulation just right immediate post-procedure. So those is very important.
And the CAT scan you're mentioning 45 days after will help you determine long-term dual antiplatelet or long-term anticoagulation?
I think both. So it's the CAT scan, we use it for two purposes. One, to make sure there are no per-device leaks and no thrombus in the device, Watchman device or Amulet device. And with that, we discontinue anticoagulation at that point.
So basically, from your Watchman program, you completely eliminated the TEE. Not completely, but majority of the cases done without TEE.
Yeah, so we have a very unique practice where we have EP and interventional cardiology integrated program, Watchman or LAA closure program, where we both perform the procedures. We both collaborate to see patients in the structural clinic for LAA closures. And so many of my colleagues feel comfortable just doing TEE, but the majority now are very comfortable doing ICE. My specific practice is probably 80% ICE, and I'm using now probably all 3D ICE.
3D ICE.
And it's regardless of the company, I can use all three catheters, and all three catheters work pretty well for guiding left edge appendage closure.
Yeah. Just roughly, how often do you cancel a case because you found a clot in the appendage?
Very rarely.
Very
rarely. And if we cancel it before the procedure gets scheduled for left atria appendage
because
closure.
the CAT scan will pick it up before.
Exactly right.
Okay,
exactly
awesome.
right.
Well, that's very interesting and unique technology, and especially for the ICE. So now for us interventionists, majority of them, like it's a big market now, the Watchman becoming a big market, or should say LAA occlusion, a big market. How we can start the ICE program? Just as a proctor, is it a course people should go to?
Yeah, that's an excellent question. We're collaborating right now with the medical industry, with companies to roll out a protocol that will be safe. Also, creating some database behind the use of ICE. I think that's very important to not just to do the procedure with ICE and say we can do it with ICE, but also have some data that you can actually mimic some of the landmark trials. For example, for Watchman, the PASS criteria, right? If you can do that reliably with intracardiac echo, which you can with 3D ICE, then that's excellent. Make sure there's no complications also in addition to when you use ICE.
Yeah.
And the same for Amulet, right? You can say the same for Amulet. Although I gotta say that Amulet has the indication to use ICE, not just TEE, but they do have included in the IFU to use.
Compared to the Watchman, it's not yet in the IFU. Because this is an ICE came after.
It's not entirely in their IFU. Their IFU is more echocardiography imaging.
Driven, yeah.
Yeah. And whether that's, you can broaden that to either TEE and can you do ICE, but they don't have the specific indication to do it with ICE.
Yeah, it sounds like the structural programs or interventions becoming like more narrow and less invasive as we day by day.
And that's the way it should be, exactly right.
Yeah.
Right? As we move along and technology gets better, we become more experienced doing these procedures. Why not minimizing some of this risk and the cost, if it's safely, to do this type of procedure, even moving towards a same-day discharge if possible.
Is your last question about the same-day discharge? Is your Watchman leave same day or do you wait for 24 hours?
Majority of them now, it's same-day discharge if it's an early procedure, if it's safe. And there's still a subset of patients where we keep overnight because they have multiple comorbidities or other medical issues that, social issues mainly, that would make them keep them overnight. But yes, we're moving. And that's an interesting point and topic because remember that Watchman or LAA closure overall is a DRG type procedure.
Yes.
So it's an inpatient procedure. So there is a protocol that to follow with that as well.
Remember that you have to keep them overnight.
Correct.
Yeah. Or you have to justify
why you're going to
sending
discharge on the same day.
Well, Carlos, really thank you for all the insight about ICE and Watchman and intracardiac imaging. I think this is becoming an up and coming and should be becoming the next thing that interventionists should know and emphasize on interventionists to know the imaging. Carlos, thanks again for your time.
Thank you, exciting.
This is great time. Thank you so much.
Yeah, thank you.
Please watch this video and others on SIF YouTube channel. This is Shadi Reyes from SIF 2022.